Thank you for this invitation. My name is Julia McNabb-Baltar. I'm the co-director of the Center for Pancreatic Disease at the Brigham and Women's Hospital, and I will talk about acute pancreatitis. Here is a little bit more information of my background. I have one disclosure. I was on the advisory board as a consultant for Nestle Health. So this is the outline of our presentation. We will talk today about acute pancreatitis, focus on diagnosis, etiology, risk stratification, initial management, management of complication, and prevention of recurrence. We'll start right away with a case. We'll talk about Mr. M. He is a 65-year-old man with past history of hypertension, dyslipidemia, type 2 diabetes, and he presents to the emergency room with 12 hours of severe epigastric abdominal pain, about 8 on 10 with vomiting. On physical exam, the patient is obese, he is maintaining well, his vital signs shows a heart rate of 95, a respiratory rate of 24, temperature of 37.2. He has fine crackles at the lung bases, some epigastric tenderness to palpation, but denies any rebound or guarding. On blood work, his hematocrit is 44.3, his white blood cell is 10, platelet count is 350. His lipase is measured at 1,500 units per liter with a normal of 60 in our lab, and the liver enzymes are measured normal. BUN is 25.2 and glucose is 521. So first question is, what imaging should be performed? A, CT scan, B, MRI, or C, ultrasound? So the answer is C, ultrasound. Let me walk you through this. So acute pancreatitis, the diagnosis is made when we have two of the three following criteria: abdominal pain that is consistent with the disease, serum amylase or lipase greater than 3 times the upper limit of normal, and if you don't have one of those two, characteristic finding on abdominal imaging. So clinical presentation, usually we have epigastric or left upper quadrant pain that can be diffuse. The pain is usually constant and can radiate to the back, the chest, or the flank. The pain is usually severe, and a pain that is dull, colicky, or located in the lower quadrant is usually not consistent with the disease. I want to mention a caveat about hyperlipidemia. In itself, this is not enough to make the diagnosis of pancreatitis. So we studied all patients presenting to the emergency room with a lipase greater than 3 times the upper limit of normal. We included 626 patients, and of those, only 52% of them had pancreatitis. The 48% of them did not. So they had all of those other different diagnoses causing the lipase elevation. More specifically, in the ICU setting, there was this study that was conducted and that included all patients admitted to the ICU with elevated lipase greater than 3 times the upper limit of normal. And of those, only 159 out of 417 patients had pancreatitis. They said that the positive predictive value was 38.1%. And the median lipase level was actually 1,164 in patients with pancreatitis versus 285 in the patients without pancreatitis. And in this group, the lipase normal was 60. So based on this, they suggested that maybe the optimal cutoff of lipase elevation levels to help us diagnose pancreatitis should be 532 in the patients in the ICU. Now, abdominal imaging. We would recommend CT scan or MRI if the diagnosis was unclear or if the patient failed to improve within the first 48 to 72 hours to assess for local complication. And this is a recommendation based on guidelines. So therefore, imaging should not usually be performed in most patients. And we've looked at imaging utilization in the emergency room in patients with pancreatitis and without pancreatitis. And you can see that a large percentage of patients undergo CT or MRI in the emergency room, and that trend is actually rising. So we're doing too many images too early for patients with suspected pancreatitis. So what imaging should be performed? It should be an abdominal ultrasound. So why do we say this? We say this because the most common etiology of pancreatitis is gallstone, accounting for 40 to 70% of the cases. The second most common etiology is alcohol intake that we see in 25 to 35%. And the third most common cause of pancreatitis is hypertriglyceridemia that we see in about 1 to 14% of cases. Triglyceride level needs to be above 1,000 to cause pancreatitis. And you can see that other etiologies are listed as common and uncommon and rare. And this is something that you have to go through when you are suspecting pancreatitis. More recently, we've seen a lot of cases of COVID and this association with pancreatitis. So we've studied this here, and we saw that about 12% of the patients with COVID who were tested for a lipase had an elevated level, and that about 3% had a rise greater than 3 times the upper limit of normal. We also assessed all patients that were admitted with COVID and found that 17 of them had a diagnosis of acute pancreatitis. And in our cohort, we saw that 9 patients were admitted with respiratory failure and later developed acute pancreatitis about 22 days from the onset of COVID, whereas 8 patients presented with acute pancreatitis symptoms in the emergency room and were found to be positive for COVID. And we showed that the outcomes of the patients presenting with acute pancreatitis were much better than the ones who developed pancreatitis after a severe course of COVID. So the initial workup that we do recommend in patients with acute pancreatitis is a triglyceride level and an abdominal ultrasound to assess for gallstone pancreatitis. And initially, ideally, the triglyceride level should be done as soon as possible, ideally in the emergency room, because very quickly the level can go down and give you a false reassurance that the triglyceride was not the cause of the pancreatitis. So back to Mr. M. His abdominal ultrasound was performed and revealed a normal gallbladder and the presence of fatty liver. He also had a chest x-ray which shows bilateral pleural effusions. And on our further history, the patient denies any alcohol use, does not smoke. His triglyceride level is measured at 1,457, and he is therefore diagnosed with hypertriglyceridemia-induced acute pancreatitis. So what is his risk of developing severe pancreatitis? So there's multiple factors that are associated with severity. There are some risk factors prior to hospitalization. Older age, greater than 55 to 60, is associated with increased mortality. Comorbid disease also increases mortality and organ failure with each comorbidity. Obesity increases the risk of persistent organ failure and mortality. And interestingly, the number of episodes, so about 100% of mortality occurs within the first episode of pancreatitis. The etiology of pancreatitis is also associated with variation in mortality. Alcohol is associated with increased mortality and probably hypertriglyceridemia as well. On admission, there's also markers of severity. We can use the systemic inflammatory response syndrome, SIRS. We can also look at single laboratory markers such as BUN or hematocrit and some severity scores. So if we look at SIRS, we usually think of a SIRS greater or equal to 2 of the following. That would be a marker of severity. So this is a single prospective cohort study that looked at SIRS and the association with bad outcomes. And you can see that in black, the more SIRS criteria, the greater persistent organ failure, necrosis, need for ICU, and mortality. And furthermore, if you look at the duration of SIRS, transient organ failure, you can see was associated with very few markers of severity, whereas persistent organ failure was associated with the worst outcomes. So really a persistent organ failure greater than 48 hours is really the bad prognostic factor. BUN is also associated with increased poor prognosis. BUN on admission, but also change in the BUN are associated with worse outcome. And this was a multi-center prospective cohort study that showed this beautifully. And you can see here the on admission and also the rise that are significantly associated with mortality, and this was validated in different centers. Hematocrit as well, so we count a hematocrit greater or equal to 44 on admission, that will predict persistent organ failure and necrosis. If you look at the severity score, Ranson criteria that were including 11 parameters, 5 on admission and 6 after 48 hours, has classically been described, but because you need to wait 48 hours to have an assessment of the severity, it's been falling out of favor. Apache 2 score can be used. BISAP score, which was developed here at the Brigham, can also be used, which looks at BUN, impairmentation, SIRS criteria, age greater than 60, and presence of pleural effusion. A harmless acute pancreatitis score is also something that can be helpful to predict non-severe course, so normal hematocrit, normal creatinine, and absence of rebound or guarding. And more recently, the PASS score has been developed. We're looking at organ failure, SIRS, pain, morphine equivalent, and tolerating solids. And this is something that you can follow up dynamically throughout the course. So if we focus on this PASS score, the pancreatitis activity scoring system, as I said, is a daily dynamic measurement of disease activity. You use those different parameters I've mentioned, and you multiply them according to discharge, and then this gives you a score. And you can see the scoring activities that varies over time and the association with no organ failure, transient organ failure, or persistent organ failure, as well as duration of stay. And you can see that a PASS score on admission that's greater than 140 is a predictor of severity. Also a discharge PASS score greater than 60 is associated with early readmission. So Mr. M, he is at risk for severe acute pancreatitis. He is older, is obese, has comorbid disease. The etiology of pancreatitis in his case is also a risk factor. His SIRS is 3. He has elevated BUN and hematocrit, and his BSAP score is 4. So what do we do for initial management? So as we know, there is no direct treatment of acute pancreatitis. So the first thing we will do is supportive care. So goal-directed therapy using isotonic crystalloid solution, which is lactated rigor or normal saline. And we usually will recommend 5 to 10 milliliter per kilogram per hour, with the exception of patients with cardiovascular, renal, or other comorbidities precluding aggressive replacement. And you really want to be aggressive early on with your IV fluids, and that if you're beyond the first 12 to 24 hours, it may be of little benefit and may potentially be detrimental. So you really want to be early on with these fluids. In terms of pain management, opioids appear to be safe and effective in acute pancreatitis. We actually looked at this and found that neither a prescription of opioids at discharge nor the prescribed dose was associated with early readmission in patients with pancreatitis. And we noted that almost half of the patients admitted with pancreatitis were discharged with a new opioid prescription, even if many of them had a pain score of 3 or less. So in this current era of opioid epidemic, we have to be careful who receives those narcotics and who doesn't need them. Nutrition is also very important. We do recommend early enteral feeding, and this is regardless of the severity, and ideally within the first 24 hours. A low-fat diet appears to be as safe as clear liquid diet, and only if oral intake is not tolerated will you consider enteral feeding over parenteral nutrition. And in terms of enteral feedings, nasogastric or nasojejunal feeding appear to be comparable in efficacy and safety. So you can use the one that is available in your center. Now, if you focus a bit more about the treatment of hypertriglyceridemia-induced pancreatitis, like Mr. M, we think of insulin infusion, plasmapheresis, and heparin. So insulin infusion, we usually will recommend intravenous infusion of insulin, and that's mixed in D5 at 0.1 units per kilogram per day to maintain a blood glucose level of 150 to 200. And then the insulin will be continued until the triglyceride level goes below 500. Usually it will take 3 to 4 days. And there's been studies that shows that IV is more effective than subcutaneous. And insulin is effective in patients with or without diabetes. And it's usually will be the main way of treating hypertriglyceridemia-induced pancreatitis. Plasmapheresis can be considered. It will help decrease the triglyceride level, reduce inflammatory cytokines, and potentially replace deficient lipoprotein lipase or apolipoproteins. that can be deficient. There's multiple case reports, case series, and there was one non-randomized control trial that has examined the use to treat acute pancreatitis due to hypertriglyceridemia-induced pancreatitis. And overall, the recommendation to use this is that it's a category 3, which is the decision should be individualized. There was a systematic review, including 8 studies, that showed that the mean pre-plasmapheresis triglyceride was 3,224, and the mean post-plasmapheresis triglycerides was 974, with a percentage decrease of 70%. And there's only 2 studies included Apache 2 score pre and post plasmapheresis, with a mean decrease in 42%. And the overall mortality was 16%, but it was not different in the plasmapheresis group. So we recommend plasmapheresis if there are signs of hypocalcemia, lactic acidosis, or if you have 2 or more SIRS, such as the temperature, the heart rate, the respiratory rate, and the white blood cell count. And it should be continued until the triglyceride level falls below 500. So heparin has also been studied. It helps decrease the triglyceride by releasing the lipoprotein lipase from the endothelial stores, which enhances the triglyceride clearance. But this change can be transient and can also actually lead to a rise in triglyceride down the line. There's also concerns of bleeding in the pancreatic bed, and there's this based on some small case series of 4 cases. Hemofiltration has also been studied. There's a randomized control trial including 66 patients that looked at hemofiltration versus heparin and insulin. The patients were evenly matched for severity before treatment, and hemofiltration achieved a triglyceride level below 500 in 9 hours versus greater than 48 hours in the heparin and insulin group. And interestingly, there was a higher rate of persistent organ failure in the hemofiltration group, and the hospital charges were 2 times higher in the hemofiltration group. So this is not something that's ready for prime time. So Mr. M, he's admitted and started on lactated ringer, 5 milliliter per kilogram per hour. He's also given insulin, IV 0.1 unit per kilogram per day to maintain a blood sugar of 150 to 200 milligrams per deciliter, and receive morphine as needed. His triglyceride level decreases to 400 in 3 days. On D3, he develops fever to 38.5. A CT scan is ordered. This is what we see. So we see it's an enhancing CT, and we see that part of the pancreas is non-enhancing, and that there's a lot of inflammation surrounding the pancreas. So what is this? So based on the revised Atlanta classification, we will define the severity of pancreatitis as mild if there's no organ failure, as moderately severe if there is signs of local or systemic complication without persistent organ failure. So necrotizing pancreatitis, as I've showed at the previous CT scan, acute peripancreatic fluid collection, and acute necrotic collection, or if there is presence of transient organs failure lasting less than 48 hours. And severe pancreatitis will be supported as persistent organ failure, and further classified as single or multi-system organ failure. And the organ failure is based on the modified Marshall score. So I just want to show a picture of this is what acute peripancreatic fluid collection looks like. You see that the pancreas is enhancing well, but there is fluid around the pancreas. Acute necrotic collection, so you can see that there is no enhancement, and that it's a collection surrounding the pancreas. So now, what about the role of antibiotics? So should he receive antibiotic at this point with the fever? So we recommend antibiotic for any patients with extrapancreatic infections such as cholangitis, but a routine use of prophylactic antibiotics in patients with predicted severe pancreatitis or with necrotizing pancreatitis is not recommended. So at this point, because he's day 3 of his presentation, it's too early in the course to have infected necrosis. And so the fever is probably from the inflammatory response, and he should not be treated with antibiotics. On day 7, he gets fevers again, now up to 39. His abdominal pain also increases. A repeat CT scan is ordered, and this is what it shows. So at this point, you can see that there's a lot of air throughout the the peripancreatic area and the pancreatic bed, and a large amount of air is suggestive of infection. So what is the next step in the management at this point? A, percutaneous aspiration of the peripancreatic fluid to send for sensitivity and culture. B, initiate meropenem. C, surgical necrosectomy. Or D, endoscopic necrosectomy. So the answer is A, percutaneous aspiration of the peripancreatic fluid to send for sensitivity and culture. Just want to say, if this is not possible, answer B would also be adequate if you do not have access to percutaneous drainage in your center. So infected necrosis, so you should consider this in anybody with necrosis who deteriorates or fails to improve after 7 to 10 days. A CT-FNA should be done prior to antibiotic if possible. And if not possible, or after you've done the aspiration, you should give antibiotics such as carbapenem, quinolone, metronidazole, and this may help prevent or delay surgical or endoscopic intervention. And there's no recommendation to give antifungal routinely at this point. So how about what's the treatment of infected necrosis? So there was this randomized trial that looked at a single center and compared minimally invasive surgery to endoscopic step-up approach. And they looked at the composite endpoint of major complication, and they found that 40.6% of the minimally invasive group and 11.8% of the endoscopic group met the composite endpoint of major complication. And we found that there were more major complication and higher costs in the minimally invasive surgical group. And there were no difference in mortality. And I just want to mention the timing of intervention. So when you have infected necrosis, you provide antibiotic. It's better to do this endoscopic step-up approach, which will include percutaneous drain placement, and then you wait until 4 to 6 weeks into the episode when the necrotic collection has formed a wall to be able to do an endoscopic procedure. So 4 weeks later, he develops early satiety and nausea, and another CT scan is ordered. This is what we see now. So we can see 4 weeks later, he does have this walled off necrotic collection, and this is something that's amenable to endoscopic intervention. So he undergoes an endoscopic necrosectomy with you see here the endoscope going into the necrotic cavity. This is what it looks like live by our endoscopist with all this necrotic liquid and material. And this is a repeat CT scan done a few weeks after this intervention, where you can see that this whole necrotic cavity is almost completely been treated successfully with the endoscopic treatment. So now if we talk a bit about prevention of recurrence. So multiple steps. So cholecystectomy is something to consider: triglyceride level, alcohol and smoking, prevalence of endocrine insufficiency, prevalence of exocrine insufficiency, and then 30-day readmission. So cholecystectomy, there was this multi-center randomized control trial that looked at 266 patients, same admission versus interval cholecystectomy for mild gallstone pancreatitis, or the Pancho trial. And we see that 3-day versus 25 to 30-day interval timing of cholecystectomy. And the primary composite outcome was 6 months readmission rate for biliary complication. And we found this in 5% of the same admission versus 17% of the interval admission. And 91% of readmission in interval cholecystectomy group occurred prior to the interval cholecystectomy. So based on this, a same-day cholecystectomy is highly effective and decreases the cost in mild gallstone pancreatitis. In necrotizing gallstone pancreatitis, though, cholecystectomy should be deferred until active inflammation subsides and the fluid collection resolves or stabilizes. So how about triglycerides? So in somebody that has presented with hypertriglyceridemia-induced pancreatitis, but actually any type of pancreatitis, a higher level that's between 200 and 500 may actually increase the risk of recurrence. And so we do recommend to start fenofibrate for triglyceride above 500, like Mr. M. Alcohol and smoking cessation. So NAPS2 consortium, which was a large American consortium that assessed the number recurrent acute pancreatitis and chronic pancreatitis, found that the risk of developing chronic pancreatitis was much higher in patients with very heavy alcohol use, as well as with smoking of more than 35 packs per year. And so because of this, we do recommend that all patients with pancreatitis should stop smoking and drinking alcohol. There's more points pointing in this. And so providing smoking and alcohol cessation counseling is very important. And the timing of counseling is important too. So for patients that are admitted with alcoholic pancreatitis, a brief alcohol intervention during admission is strongly recommended. And this is based on a randomized control trial that compared repeated 6 months interval intervention for 2 years versus a single intervention during admission. And it showed no statistical significant difference, but a trend toward reduction in a hospitalization in the single intervention during admission. So this one-time intervention when the patient is very sick seems to be as effective as multiple interventions. And so it's very important to do this. How about endocrine insufficiency? Meta-analysis shows that pooled prevalence of prediabetes was 16% in the patient following their first episode of pancreatitis, diabetes in 37%, and insulin dependence in 15%. And the prevalence of diabetes less than a year versus 5 years later was 15% and 40%. And there was no impact on gender, etiology, or age. So an important take-home point is that screening for diabetes after discharge is important, especially in necrotizing pancreatitis. Exocrine insufficiency is also an important thing to think of. Another meta-analysis looking at the rate of exocrine pancreatic insufficiency at a mean time of 36 months after the pancreatitis showed a direct testing pool prevalence of 42% and higher rates of exocrine pancreatic insufficiency in alcohol, severe pancreatitis, necrotizing pancreatitis, and decreased rates over time. So a take-home point is that pancreatic enzyme replacement therapy is important for those with alcohol-induced pancreatitis, severe pancreatitis, necrotizing pancreatitis, and we do recommend to check fecal elastase after 4 weeks to evaluate for ongoing exocrine pancreatic insufficiency. Finally, readmission. So using the analysis from the National Readmission Database, we found that about 16% of patients with pancreatitis are readmitted within 30 days. And the risk factors for all-cause 30-day readmission, including younger age, non-home discharge, increased Charlson Comorbidity Index, so increased comorbidity, and increased length of stay. And as we said before, in-hospital cholecystectomy reduced readmission rates by 54% in the gallstone pancreatitis. So take-home messages. Number one, utilize early diagnostic CT judiciously, only if you're not sure if this is truly pancreatitis. Evaluate severity with all the different tools we've talked about. 3, provide early goal-directed fluid resuscitation. 4, initiate early oral feeding when tolerated, regardless of the etiology. 5, initiate enteral rather than TPN if oral feeding is not tolerated. 6, avoid the use of prophylactic antibiotics. 7, avoid ERCP in the absence of cholangitis or persistent choledocholytitis. And then 8, you have to delay intervention in infected and sterile necrosis at least 4 to 6 weeks. And 9, discontinue alcohol and smoking in all your patients. Thank you for your time and attention.